Dr. Titus, you're ready to go? I'll call it in a minute. So you want me to have, you want to speak into that and have?
Sure. All right. Can you hear me? Is that good enough? Okay. Good morning. Thank you for coming to listen to us talk this morning about some of the work we've been doing. We're presenting this morning on the hybrid treatment of complex aortic disease, and going to do this with a demonstration of some case presentations that kind of illustrate our points and some collaborative efforts that have been going on here. So if you look at hybrid treatment, it really follows the endovascular revolution of specifically aortic disease and endovascular treatment of that. If you look at a starting time point, most people in vascular would point to 1991 when Dr. Perotti, who's pictured there, did the first EVAR. And what he did was he sewed a Dacron graft to an undeployed stainless steel stent, advanced it into place, and deployed it with a standard angioplasty balloon to treat an aneurysm in a patient who was otherwise unsuitable for open repair. It was successful and kind of started the revolution of technology to the point where today these are just the options we have for infrarenal devices and advanced to treatment of the thoracic aorta and all our thoracic graft options. And then we've moved on to more complex repairs with the development of fenestrated stent grafts for treatment of the visceral segment, along with designs currently available with pivots or even branches built in for the abdominal aorta. And then now in trials, we're moving on to the arch and arch branch devices with fenestrations for the head and neck vessels. So a lot is happening, and in our current environment with these newer options, approaches, and thinking, the real question is, which option's best, which option's correct, and unfortunately in math, usually there's only one correct answer, but in endovascular treatment or hybrid approach to these patients, I think there are multiple right answers, and so the advantage of a multidisciplinary approach is I think it brings in different talents, different ideas, different experience, and really allows us to troubleshoot and get to the best treatment for a particular patient, looking at all the options we have available, trying to make it as minimal insult to the patient as possible with the best long-term outcomes. We've had our dissection meeting, which meets quarterly, and this is attended by cardiology, cardiac surgery, and vascular surgery. And this has really turned into a good multidisciplinary meeting. We've developed some protocols for dissections, and along with that, it's transitioning into a aortic meeting where we can bring cases and discuss approaches to that treatment. Along with that, we have our Wednesday morning conference, which cardiology, medicine, internal or interventional radiology, and vascular are there. Anyone is welcome to come, where we discuss complex cases and a good approach to them. So without further ado, we are going to present some combined cases that have been done with cardiac and vascular that illustrate kind of, I think, a good approach to these patients with very difficult problems. So if Ben wants to come up. Our first case is Casey, and she is a 71-year-old male who was transferred here from another institution for unstable angina and a questionable symptomatic thoracic aortic aneurysm. Pretty significant coronary history. Starting in 2000, where in Florida she had at least 4 stents placed, and then in 2010 had severe restenosis, had a PCI here actually, complicated by dissection and treated medically. And then in 2012, again, severe stenosis, atherectomy, and PTA, and they noted that there was an abrupt recurrence after the atherectomy, which really signified her ability to create neointimal hyperplasia and very likely problems going forward. With respect to her aneurysm, she'd had a known juxtarenal aneurysm for years, which had been followed by her primary care. It had been small 6 months before her presentation. On a CT scan, it was 4.2 centimeters. Interestingly, with this, she had never had her chest imaged until a chest x-ray for bronchitis showed enlarged aortic calcification. She had a chest CT done that confirmed a 6 centimeter at that time thoracic aneurysm. And she had seen a thoracic surgeon or cardiothoracic surgeon and was undergoing evaluation for possible repair. In preparation for that, she had a stress test ordered, which actually she presented for and then told the techs and the people, oh yeah, I've had chest pain, you know, with any activity I do, it's getting worse, and now even when I'm sitting here resting, I do have, you know, some chest discomfort. It seemed to get worse over the past couple weeks after an episode of acute left-sided thoracic pain that was scapular and very vague in nature, and she said it was bad when it started, and it kind of started to subside, but never truly had gone away. So she was admitted at the other institution with a troponin elevation and underwent cardiac cath as well as a CTA. I think Glenn will talk about the cath here. Sorry. Yeah, just double click.
Okay. So you can see on this shot she's got a tight LAD. And she has a tubular long lesion in her ramus intermedius here. Okay. And then on the right shot, she's got an instant stenosis of her right. She's got a right dominant system. Oops.
Yep.
So I thought that the only one really worth going was going to be the PDA. This looked a little bit small. This is a very large system here. So well, I don't know if you know the imaging. The ascending aorta was a little bit calcified, so initially I thought about doing her as an off pump. But in the operating room, as we were going after her LAD, it was really quite deep in intramyocardial. So I spent a lot of time digging it out. I decided the safest thing to do is go on pump and cross clamp her, which I eventually did. And so we grafted her 3 vessels, LAD, ramus, and PDA.
And so that was the plan from the cardiac perspective, but she had this thoracic aneurysm, and it was felt that this was very likely symptomatic. It had grown to 6.4 centimeters, and along with that, I'll show some demonstrated slides of kind of the issues when we are considering our approaches. But she also has this juxtarenal aneurysm and pretty severe iliac occlusive disease. So these are just kind of some slides that we talked through when we were looking at an approach. First of all, in putting our symptoms together on this slide here, if you can see, we actually found a piece of calcification, and then it had ruptured interazygous system, which very likely prompted the worsening of her coronary disease. Along with that, she had this cluster of atheromatous disease, and this is just at extending distal to the origin of the left subclavian. Obviously, when you're thinking about doing a thoracic stent graft repair of an aneurysm, pushing a device up, seeing something like that, pretty high risk for stroke, and that's a scary lesion there for us. Along with that, the juxtarenal aneurysm, which has kind of a double bubble configuration. You can see the origin of the right renal, which is the lowest one there, the aneurysm coming right up there, along with severe occlusive disease of her iliacs, which we can do something there to get a thoracic device in, but if it's met with any complication, we have a juxtarenal aneurysm without a device to treat it there, which would run you into a lot of problems. And so the discussion was kind of, I don't want to do a thoracic repair with all of these problems in a patient with active and unstable coronary disease. And I think you can talk about symptomatic aneurysm, right, coronary bypass.
Right. So the idea was, you know, if we were going to go to do this, what's going to, you know, we have 2 major problems that are life-limiting, life-threatening. And so the thought was to do this as a combined approach and try to get both of these together if we could. Now, whether or not they could do this from the groin, obviously I defer to Jess and her team, and thinking that going up from the leg was going to be a particular challenge. But, you know, for us, we have an easy access. Once you go into the chest, pretty much we have access to almost anything. So the thought was to do, you know, something combined. And there are various ways of approaching this. First, we can, you know, I'm, as you guys know, I'm an off-pump guy. I like to do things off-pump. But that's more for preference than for anything else. But this can be done certainly on pump and cross clamp, which is what we ended up doing. But the idea, once we access the ascending aorta and we have the chest open, we have access to an antegrade approach to these therapies. The big whack can be done also surgically. The old days, we would have considered doing a big surgical approach where you can, even from the front of the chest, go on the heart-lung machine and circle rest, and then lift the heart up towards the right, and then hit the descending thoracic aorta behind the pericardium posteriorly on the left side. But that's, that's a historical operation at this point because of the approaches that we have with stent therapy.
And also the benefit of an antegrade approach and a conduit onto the ascending makes this less of a scary lesion because you have some control. You're sticking it much closer. You don't have the torque of coming through a tortuous aorta. And also you're pushing it antegrade, which if I have to get it out of the legs, that's better to me than having to try and declut it from the head. So we decided to do the cabbage, and then he sewed on a Dacron conduit for me to approach the aorta. Do you want to talk about the case?
Yeah, so when we first started off, as I said, we thought we could do this off pump. She was a little bit older lady. We thought it might be, be a little bit better from a bleeding standpoint. But going in, her LAD was so deep that I just, aborted, and we went on bypass cross clamp. Did her bypass grafting first, but we were still on the heart-lung machine, so I did a Lumina LAD. I grafted that ramus as well as hit the PDA. They were good targets. And then we stayed low enough on the ascending aorta so that when we cross-clamped high up, we could sew a graft onto the ascending aorta, 14-millimeter graft, so that they could pass the stent. So at that point, we took the cross-clamp off. The heart was beating, and then we approached the stent.
And I think going low on the ascending, as Ben said, is a very important point because that gives us a very nice trajectory for our access. And what I do is I take the Dacron graft and I actually sew it to the skin to give us some stability. And then I clip off the graft and actually stick the graft much like a native vessel because that gives you no bleeding around the sheath. If you try to do a vessel loop and through the Dacron graft, you just bleed the whole time. And so with that, we had a lot of stability. We had a very stable system. You can see here, this is the pigtail coming in from our ascending angiogram with the thoracic aneurysm. A nice landing zone here, and that was key too, is looking at this. We could get a stent graft in with seal distal to all that atheromatous debris, and we just wanted to avoid that completely. You can see it, kind of the borders of it there, and this is left subclavian. So we put in a C-tag. This is our completion shot from a proximal perspective. Very good seal there. We avoided the atheromatous area completely. And then we added an additional stent to bring it down to the celiac to ensure we had a good seal zone there. You can see very good filling of the celiac and SMA with no evidence of endoleak there. So postoperatively, she did quite well. The beauty of the stent grafting is if they don't have any neurodeficits, which is what we watch for when we treat the thoracic aorta, then their recovery essentially just becomes that of an open heart surgery. And she followed that pretty routinely. Discharged post-op day 8 to cardiac rehab. She was readmitted 1 month out. She went in with persistent dyspnea and exertion and fatigue. She just didn't feel well. They thought maybe she had a P, so they got a CT. The thing that they found, which continues, is when we put a conduit on, we just oversew it. You don't try to take it off the aorta and repair the aorta. So you cut the conduit down and then you oversew it, and that has been a fake out for a lot of people. And so she was transferred in for a pseudoaneurysm of the aorta, of the ascending emergently, and so we saw her and said, "You're fine."
The graft
yeah,
that we announced too. So we reassured her that.
That was an expected finding. So I've seen her, I've followed her now for her juxtarenal aneurysm. She's stable in size. It's about 4.6 centimeters. So thankfully this has not changed. She's still, well, she quit smoking initially, went back to smoking.
Back to smoking.
But otherwise she's doing quite well. So I think a good solution for a difficult problem there. Our second case is
very interesting.
yes, he's a very difficult guy. So he was a 63-year-old male presented with a constellation of kind of weird symptoms. He had unstable angina that had been worsening, along with dizziness and recurrent syncope. The dizziness and recurrent syncope were related to activity pretty clearly. He also, on further questioning, had bilateral arm claudication, but this was somewhat limited in that if he used his arms enough, he would just pass out, and so didn't have time for them to become completely numb, and it was both arms. So past medical history is pretty significant. Coronary disease, he had 2 previous stents. He had iliac stents, COPD, but he was not on home oxygen, CHF, hypertension. History of a TIA that was right upper extremity weakness, I believe, but hadn't had any symptoms for a while, and continued to smoke. So he presented actually out of state with these symptoms that had been present and progressive. I think he had an episode of syncope and was brought in. So he was admitted there and actually found to have an elevated troponin, underwent a cardiac cath, which we can't see.
We can't pull it up. It was loaded up on our PAC system. I can't get it. Anyway, he had 80% left main, 80% Prox LAD, 80% circ, and a high-grade lesion in the PDA. So he actually needed 4 grafts based on his cardiac anatomy, and his EF was mildly depressed at about 40%.
And the other concerning thing they found during the cath was that he had severe occlusive arch disease, so 90% stenosis of his innominate, along with occlusion of his left carotid and left subclavian. So at that point they said,
Hunt.
Yes. So from a couple of states away, he came to our institution, which is actually a huge compliment, I think, to be transferred from far away for us. And in approaching him, we considered different routes and different points. Again, active chest pain, not wanting to do a big arch reconstruction, but I think.
So he has a totally occluded subclavian, so we didn't have an IMA to work with on the left side. He had a 90% innominate on the right, and so we don't really have the right to work with. So he could have gotten all veins or radial arteries, but we didn't actually study the radial arteries at the time, thinking that we weren't going to get a good study just because he had already claudication on arm. So he was essentially going to get all veins as one option. I guess I could have used the gastroepiploic for his PDA. The question became, well, can we open up one of these vessels beforehand so that we can get one of the IMAs to be useful? The fact that he essentially was perfusing his brain with a 90% innominate, we did do a CTA of his head and made sure that his circle of Willis was entirely intact, fortunately.
Yeah. So I mean, that was a big concern too, is putting somebody on bypass with the only flow to his head through a 90% lesion. And so in looking at approaches and considerations for that, we said, let's see if we can get through his left subclavian, stent that, at least that gives you antegrade flow to the brain through the vert, as well as gives you guys a lima, and so offers some protection. And so this is the angiogram, left brachial axis. You can see a very large vert there, and actually on ultrasound, this is retrograde flow. But coming from the arm, it's obviously going to fill. And then able to get through, this is the pigtail in the ascending thoracic angiogram to confirm we're within the right position. You can see sliver of flow here filling into the innominate with post-stenotic dilation there. He had actually a huge innominate for the majority all the way up to the bifurcation. So put in an ICAST 8x38 stent. And you can see actually on the initial films it was very difficult to even pick up the lima because it wasn't really doing anything significant at that time. But here, vert's wide open, filling well as this is a better projection of the lima, and the stent kind of comes right up to the lima, but no residual stenosis. So in planning for the operating room, we said, should we, we were going to do the aorta innominate bypass. We said, should we do the left carotid? So we got a CTA to see what that looks like. And you can see it's actually occluded all the way up here. And so at that point we said, risk versus benefit. It's not worth, you can open them up, go and do a carotid endarterectomy and long bypass there, but it doesn't make a lot of sense in that his symptoms are all global cerebral hyperperfusion. This is not embolization from the left side. It's occluded, just leave it alone. And we're going to get him such better blood flow through the antegrade vert on the left, as well as opening up his innominate. So procedure-wise?
So they opened up the subclavian. Now we do have the IMA to work with on the left. So from my standpoint, it becomes revascularization of the heart becomes very easy. So that was relatively straightforward. We did a CAB4 Lima LAD, I did a sequence to his ramus, and an OM2 as well as a PDA. So that went relatively unremarkably, which was good. But then the question was, what else should we do for him while we were there?
And I think too, he had plaque and calcification in his ascending, which made a little bit position of the innominate bypass a little bit difficult. But we were able to.
We put a side binding clamp, so down actually low on his ascending aorta. He had a lot of plaque disease. So even though I didn't cross clamp him down there, but so I used we have a punch device that we could use, so I can do a proximal without putting a clamp on his aorta. It's called a heartstring 3. I actually had a video of it. I couldn't get it. It's only online. And but anyway, it basically is an umbrella that you put into a hole there, and you sew over this umbrella. And then when you're done sewing with it, you just unwind the umbrella, it slides out, and then you have it proximal. So we did that. But up high, he had enough disease in the aorta that cross-clamping him didn't make a whole lot of sense either. But he had a small enough area that I could put a small side biter just below the innominate. His innominate was a rock, as you can imagine, because he had a short segment of totally or 90+% occluded innominate. So we put a side binding clamp on his aorta just below the innominate, and we can sew a 14-millimeter graft onto it to help bypass the innominate.
Yeah, and then we just transected it totally higher up and did an end-to-end distally on that. Post-operative, he did quite well considering all he went through. Had a couple issues. He was extubated post-op day 1. On post-op day 9, he developed this new trifascicular block, was evaluated by Dr. Singh Gupta, and had a dual-chamber permanent pacer placed on post-op day 10. He had acute HSV, he had a fever, and then ID saw him, worked him up, which is a bit odd. And this was adequately treated with oral acyclovir and magic mouthwash. He had severe COPD, so not surprising that he had respiratory insufficiency, but was discharged home on post-op day 11 on 1 liter of O2. He has elected to follow up locally since he's from so far away, but we have heard he is continuing to do well with no neurologic or cardiac symptoms at this point. So that is me and Ben, and now I think Jesse and Ben are going to present yours.
Thanks again for the opportunity to present. I hope today, at the end of this presentation, we'll discuss some of the options available for arch aneurysm treatment or arch pathology overall treatment. We'll be using a patient case to kind of highlights those treatment modalities. This is my disclosure. The patient is an 80-year-old female that presented to her primary care physician with progressive hoarseness that had been present for several months. It was getting worse. Her past medical history was significant for ductal carcinoma stage 2, rheumatoid arthritis, and hypertension. You can see her surgical history there. Her social history, she was a former smoker that quit smoking in 2013. She's retired. Wasn't on that many medications. From there, she was referred to ENT, who did a direct laryngoscopy and was noted to have left vocal cord paralysis. she's now, the ENT actually thought that this was malignancy, so obtained a CT scan of the neck and upper chest. Was surprised to find a circular aneurysm that was causing this. Further history there took place, and the patient denied any history of trauma or deceleration injury to her recent or late at all. This is a CT scan. I'll go through a few things with you. You can see up above, we start here, so the 3 arch vessels, innominate, carotid, and subclavian. As we come down, you see another vessel that's coming out, which very easy to forget. So you start asking yourself, what is that vessel? It's not supposed to be there in the normal anatomy. As we come down, you start seeing the arch, and we come further down, you have the ascending, and you have this aneurysm here, and you have the descending aorta. You can see the aneurysm is quite big, and that's the rest of it. Is a 3D reconstruction. Again, looking at the location of the aneurysm, you see that this patient has, instead of 3, 4 arch vessels immediately. I'll show you a better picture of that. This is from my center line of flow. I was able to show you have the innominate, you have the left carotid, and I determined after getting a CT head that this was actually, I thought it was perhaps a inferior thyroid artery, but it wasn't. It turned out to be a left vert that was coming directly off the arch, and this is important to help determine the treatment. And then you have a left subclavian artery. The patient was referred to Dr. Sun for evaluation of for repair, and subsequently to me. And I'd like Dr. Sun to come up and maybe talk a little bit about option or what.
Yeah. So for just, I'm going to just switch over real quick to talk about some of the surgical approaches. Okay. There's some surgical approaches to to the arch. This is a standard kind of single Correll patch head vessel procedure that we'll do for either dissections or aneurysms. A fairly strict way. You cut the ascending aorta off and then do a graft. You can do a single Correll patch with 3 head vessels. If there is disease going up into the head vessels, they can be implanted individually as well. This is typically done under deep hypothermic circulatory arrest, so about 18 degrees centigrade. But there are strategies that you can be perfusing the head as you're doing this, which is just beyond the, I won't talk about that now. But the other technique that we use to address aneurysmal disease is an elephant trunk. And I know, I've talked about, people have seen us do it, but people don't understand the concept. And what it is essentially dealing with an ascending aorta and a descending aortic aneurysm at the same time. And historically, this was described when you would fix, coming from the front, the aneurysm at the neck of the beginning of the descending thoracic aorta. So this actually is a suture line. So you sew this here, down in the past the subclavian, and you basically let a piece of Dacron flop down into the descending thoracic aorta. That's the elephant trunk. Okay, the rest of it is the same in terms of arch surgery. So you just reattach the head vessels. You can plot either as a single patch or multiple patches. But this is the elephant trunk. So there's actually a suture line here. So so this area is fixed up to here. Now, in the old days, prior to having stent, we would go back in to a left thoracotomy, open up the aneurysm, and just grab that graft and clamp it immediately, and then we have something to sew to. And that was the completion of an elephant trunk. Nowadays, we don't have to do that. We basically can just, have our vascular teams go up with a stent and take care of it then. So this is an elephant trunk. So when you see this on imaging, and you see blood going backwards around this thing, it's not a dissection. The suture line is here. This is just here to get the flap. Nowadays, there's we can talk about doing a frozen elephant trunk. So the same concept, but instead of sewing the graft here, we can use a stent and deploy this at the end and then sew this up here. So this is frozen with a stent, hence that's the term, frozen elephant trunk. And then when you talk about, as we're moving towards other approaches to the ascending and descending thoracic aortas and arch aneurysm for stents, there are, as you start to talk about, there are 3 areas of landing zones in terms of where the proximal area of the stent goes. And I'm just showing this, that this exists. It's having a dialogue about what about each landing zone is different, is a complex dialogue. But obviously, if you're, ascending aorta is zone 0, zone 1, zone 2, and depending on where the proximal landing zone is going to be, you have a different approach into the head vessels in terms of how you approach it beforehand. And these are different debranching styles that exist. And again, this is just to expose you that it can be done. You can totally debranch the head vessels through a stent across the arch and take care of it, as well as everything back to what I showed before, which is a frozen elephant trunk. So these are the kind of the surgical approaches to the aorta nowadays.
Sure. So another patient was 80 years old and didn't quite seem to have that many medical history. She looked actually older than her stated age, and she looked quite frail. So when I saw her, we talked a little bit about different options. Would be open surgical repair. She said that's not an option for me. A hybrid repair, we said we'll make incisions from essentially this side of the neck and this side of the neck, do a carotid subclavian bypass, tunnel the graft under, and then put a stent graft. She wasn't too hot about that either. She said, I have to ask my pastor and my primary care physician. One of the other option is a chimney repair, which really I'm not a big fan of. This is a repair that a lot of vascular surgeons are adopting for essentially get me out of trouble in the middle of the night. If the patient shows up with a say rupture of the arch, you can actually sandwich a graft. If we have time, and at the end I'll show you some pictures of this technique. We don't like it because 1 year on published reports, well, number one, risk of stroke is as high as 23%. Number 2, underleak, because you're using 2 different lumen within the same lumen, 2 grafts within the same lumen, is up to 40%. So we don't like that. Or you can custom a graft, design a graft, such as a fenestrated or branch undergraft for this. So we wonder, why is this a part of a hybrid procedure? Where anytime you start getting wires very close to this level here, you have to start thinking of a few things. Number 1, you have aortic valve. You have to look at the valves. Your wire can dissect it. You have to have a cardiothoracic surgeon there, because if anything happened, they have to be ready to open this patient. Otherwise, this will cause a patient demise, as you can imagine. But the most important thing is what we call the wind socket effect. So pressure is pretty high here. When you're deploying your graft, once you deploy it, it probably won't stay where it's at. It'll be pushed back this way. So you have to take that into consideration. Talking with anesthesia at the same time, asking them to lower the blood pressure. Sometimes we use rapid pacing to deploy grafts at this level. You have then to take into consideration supra-aortic branches. Stroke is still the major risk factor due to embolization in this device. And then you have to look at the curvature of the arch. The arch we graded is at 1, 2, or 3, based on if you draw a line from here all the way down, do these vessels are all staying at the same level, or are they staying down? So a patient like this will have probably type 2 arch, I would call. Then you have to look at a phenomenon known as a bird's beak phenomenon. So if you land a stent graft right here, is there going to be a good opposition in the wall of the aorta above and below? You have to consider all of this. If your your arch comes this way and goes down this way, it's a big, big question mark and a steep angle, then landing a stent graft here is not a good idea. You should be landing it probably someplace here because you won't get a seal. Then you start looking, if you're coming down all the way here, this wasn't the case this time, covering the critical artery of Adamquist. You have to maintain the blood pressure high, otherwise the patient becomes paraplegic. If we're dealing with branches, you have to deal with embolization, perfusion of the hypogastric, very important, and access. So when I'm considering implanting a device in a patient, you have to look at a few things. What is the angle of the infrarenal and the suprarenal aorta? Which way should we implant the graft? Should we come from the left groin, or should we come from the right groin? Because depending on which groin you come from, the device will actually confirm to the body once you pull it up. And it might become very, very difficult if you go with a fenestrated stent graft for this to line up. And if you start looking at a patient like this with an arch aneurysm, then you have to determine where you're going to cover and what vessels are included in your coverage zone and the device that you want to use. This is the old device that we used to use. This device is no longer produced. This is the device I like to say is the device I grew up with. I'm very, very comfortable with this device. In fellowship, we deploy it and we modify it, we implant it in patients. The device has been, the company now stopped it and they came up with this device. A few months ago, I met with my mentor when this device came out. We said we're gonna modify it. And we tried to modify it and everything, and it went very well, start sheathing it. And we ran into big problems. These are laser cut, these are very, very strong piece of metal that are aimed to anchor into the graft. We could not sheath it at all, so the project was kind of aborted, and then we went to, well, maybe we can kind of cut these out. If we cut them out, we could sheath them, and then we're cautioned by the device engineers that this was not a good idea because it messes with the integrity of the graft. It's in fact long-term, the patient can't survive. Well, the design, the repair won't survive long-term. Was lucky to get the device from the company. This was my kitchen countertop. I was messing with it a little bit at home, and I was able to finally figure out how to get this graft to work without cutting those barbs. And this was because of I found out that I could take a bifurcated device, this is an expired device that the company gives me, and if I were to put in this hemostatic valve through this, we'll be able to do it. So this is the center line of flow that we obtained for our patient, showing that the nominate was coming out at 1215. This is another area that's completely different from a regular fenestrated stent graft. When you're sizing a branch stent graft for visceral arteries, you're having the spine as your backdrop to go with your, to determine your center line. But when you start doing the arch, you no longer have the spine, so you have to rotate it in a different way. So it's 180 degree different than what you usually do. We found the left common carotid artery, the vertebral artery, and the left subclavian artery. There's a lot of reports about this left vertebral artery in the vascular literature, is that if the patient has a complete arch, you can sacrifice it without a bypass. But if the patient does not have a complete arch, you have to do a bypass to the vertebral artery, otherwise the patient gets a stroke. This patient did have a complete arch, so it made the case a little easy. This is the actual case. The graft is completely deployed. You see a needle. You probably wonder why we're putting a needle here. And the reason for that is because this graft here is sized to the aorta of the patient. And we're trying to constrain and make it a little smaller. When we put it up in the aorta, in the arch, we still have the ability to move it one way or the other so that the fenestration can line up completely. So this is the constraining wire. This is a very tricky area here because if you essentially putting this wire here and here, the string here and here to pull it together, that if you pull this wire out, they have to fall apart. If they don't, then you're done. This thing gets stuck and it's not constrained. Now, I've seen a lot of people make a mistake here. So that's the fenestration that we made, and this is the delivery system. We're trying to mount the graft back into the delivery system, and we're trying to now tighten the graft up to put it into the delivery system. This is the system that we divide. We can go into 2 different sheaths, 18 sheaths and 22 sheaths, and then go into this delivery system finally. Then the graft is almost in the delivery system, and now we're ready to implant it. So this is a picture from below. We do an angiogram when we come from the arm. You see the aneurysm is right there. The device is advanced. Now the device is still constrained. We come from the arm. We're able to get through the fenestration and into the graft. I think this is a picture showing us we are in fact into the graft, and the other arch vessels are perfusing well. And then we took the constraining wire, deployed the graft, balloon it. After ballooning it, we put a covered stent in a subclavian artery, and then do a completion angiography that shows that the aneurysm now is excluded, and there's no evidence of endoleak. Patient was admitted directly to the vascular surgery floor. Postoperative course was uneventful. We obtained a CT scan prior to her going home. You can see this is the subclavian artery stent coming there. All arch vessels perfused. This is a stent graft where the aneurysm was, which was right here. Now the aneurysm is no longer perfused. It's excluded. This is a 3D showing all arch vessels are essentially perfused and the aneurysm is excluded. This is what I called it has different names: chimney, sandwich, Brazilian, you name it. Essentially, you're coming from the arm, coming down, and then you have a stent graft right here. Your end result is this. So the subclavian is getting blood from the descending aorta going up. This is the a procedure pioneered by Dr. Gene Penneton in Norfolk, where you can come in, you can laser this thing here. The disadvantage there is that the graft is not sutured around, and if you balloon it too much, it causes a tear in the graft, and you have an endoleak. This is the only device that's currently now undergoing trial in the United States, a Gore device that you do a carotid subclavian bypass, and then you can deploy the graft with a Gore limb, as you see here. The limb is specifically designed just for the arm, and it's deployed, and you see where the bypass goes. It goes behind the esophagus from the carotid to the carotid and then to the subclavian artery. The next case.
One more case.
Yes, sir.
You think that was more like a pseudoaneurysm related to a penetrating ulcers?
Yeah. Yeah, so this has been described before. It was actually described by an Australian surgeon, the cardiac surgeon will probably know if I butcher his name, Dr. Ortner. Yep, it's called the Ortner syndrome. What it was normally due to was actually hypertrophy of the left atrium, enlargement that compresses on the recurrent laryngeal nerve. But most likely, this lady probably had an accident that she didn't remember, and she had the aneurysm was right where the ductal would be, and developed an aneurysm and that grew over time. Perhaps I'll let Dr. Sun comment a little more on the etiology, but that was my thought. But probably it was a trauma that she never really knew she had.
Which, until I look it up on this paper too.
Ductal aneurysms, which exist, there's only been a dozen cases reported, and it's typically in this age group. They're like between 60 and 80 that they show up, and they present exactly how she did, which was just hoarseness. She doesn't recall any trauma, but it's rare, and they do well if they're repaired surgically, but there are a couple of cases where they just were found at postmortem.
So I'm going to present the case of a hybrid approach for type A dissection. This is a 66-year-old, very healthy guy, former marathon runner, history only of hypertension, and then there was some suggestion that he may have been diagnosed with an aortic aneurysm at some time. Only medication with lisinopril. He had sudden onset chest, back, and abdominal pain, and what sounds like probably a syncopal episode. He crawled to the phone and dialed 911. He showed up in the emergency room with, he was delirious, but non-focal neuroexam, hypotensive, and significantly acidotic. So we were obviously concerned. Well, here's his CT scan. He had a very complex dissection with multiple tears in the ascending and arch, occluded renal, left renal, SMA, IMA, and left iliac. You can see the iliac is occluded there. So significant, very significant malperfusion. And we're probably about 4 hours since time of symptoms at this point. So it's a significant therapeutic dilemma. Is the patient salvageable at all at this point? If he has a substantial mesenteric ischemia, he probably is not survivable. And then if you think you want to try to save this patient, there are various potential approaches. No good data to favor any of these really, so it's kind of a bit of a guessing game. But the traditional approach for a type A repair would be a Bentall procedure with exclusion of the false lumen. Obviously, if he has mesenteric ischemia and significant malperfusion, you may want to address those things first. So we discussed that with vascular surgery and interventional radiology. Ultimately, we decided on a traditional Bentall plus an endovascular elephant trunk, and then an intraoperative exploratory laparotomy to determine to determine if the bowel in the patient was viable. So we took him to the operating room. General surgery opened his abdomen, examined the bowel, which appeared viable. I initially tried to cannulate the right axillary artery, which is the preferred approach because it gives you antegrade flow on cardiopulmonary bypass, which stands the best chance of not causing changes in the dynamics of flow and worsening malperfusion. Unfortunately, his artery was dissected when I encountered it. I then went to the ascending aorta, which again would give you antegrade flow. We accessed the true lumen with a wire, put in the cannula over there, and there was some stuttering, probably a dynamic flap near the cannula. Wasn't entirely happy with that. It can be catastrophic if you initiate cardiopulmonary bypass into the false lumen or somewhere where it's not supposed to be. Ultimately cannulated the right femoral artery, which had good flow and was not dissected. Did the traditional reconstruction of the aortic root and valve, and the picture there kind of describes what that is. But when we did the distal hemiarch under circulatory arrest, Jesse and his team deployed an endovascular stent graft down the descending. The thinking being, and there's again no long-term data to support this, this is really only based on theory, that you will improve the likelihood of true lumen flow and hopefully obliterate the false lumen to a large extent. And so you can, Jesse, maybe you can just say what you did. If there's anything specific.
So this patient, I actually tried to talk the wife out of doing anything, and I've been proven wrong. In this case, because you see lactate of 8, and patient very tender, it's been 4 hours, and we're pretty sure we'll find dead bowel. This is the middle of the night, I think it was about 10 or 11 o'clock at night. But the wife and the priest, I was there, and the sister, no, we have to do everything. So we said, we'll look at the bowel with general surgery. If the bowel is dead, it's just going to close. We won't do anything. We're quite surprised that once we got there, we opened the bowel looked viable, because on CT scan, don't know if you have it, everything was closed down. So our job in this case is actually really, really straightforward. It's very easy. They got the hardest work to do. We got access from the groin and went all the way up. And once it was done, I just deployed a stent graft. We go with the shortest stent graft possible, and then did an angiogram. And
I'll show that, although I can't advance the slides anymore. Whatever was just done.
I can do that.
Okay. So this is an angiogram after completion of my portion of the aortic root reconstruction. Shows reconstruction of the root, patency of coronary arteries, and flow into the true lumen of the arch. Next. And this is your completion angiogram here. We're just at the distal end of the stent graft, and you can see that all of the visceral arteries are being fed, SMA, IMA, except for the left renal is still out. But all of the critical arteries, and next slide, and again reconstituted down. Now the left iliac is also open. So everything critical is perfused. And the patient did and continues to do well.
Right. He did quite well, and his renal function was actually normal after the, so normalized after the operation. The right kidney was hyperperfused. I got an ultrasound, and I did take him electively and put a stent in my kidney artery because it wasn't being perfused, and now it's well perfused. The kidney is well perfused. It's done quite well. He's resumed biking, and his aorta continues to remodel, and he's working. He's doing well.
That's it. Any questions? Any other questions? Yeah, Kevin.
Jesse, do you want to talk a little bit about how many of these hybrid cases you've done and the process in the night for people?
Yeah.
I mean, obviously, this is revolutionary stuff. It's great for our program. It's great for our patients.
Yeah. So it's not a well-oiled machine yet, but we're getting there. It's a new program. The idea is that anytime we get a dissection, 3 groups will get consulted right away. We'll add the 4th if needed. So the 3 groups that will get consulted will be cardiology, because these patients need their blood pressure managed. We'll get cardiothoracic surgery, and we get vascular surgery. Get consulted right away. Regardless of what is it, type A or type B, let us determine that, because sometimes you get someone, it's a dissecting aneurysm. What does that even mean? It's best for us to just take a look at it and then determine what the best therapy is. And then from there, the team gets together. If we need general surgery to come aboard to do a laparotomy, then we approach them. We've done a number of these. I'm not sure how many. I think about 8, maybe 10. Since we've done a lot more type B aortic dissection that we've treated with stent graft. But again, our goal for this year is to not miss a single patient. So like cardiology, cardiothoracic surgeon, vascular surgeon always talk to on all these type B aortic dissection. Traditionally, it's been dealt about by cardiac surgery, so it's easy to just forget the vascular surgeon. But the pendulum has swung the other way, and now the treatment calls for all these 3 specialties really to work together, and that's what we hope to achieve moving forward.
And that also means that we take up a lot, because we'll get these calls. And, you know, the nice thing is sometimes I can pull these films up at home, and the first thing I'll do is set up room 5 as opposed to, we typically, for a type A dissection, the regular room is set up, which is room 2. And so we have to divert that. And then because vascular is not always called with it. So it's right now it's the onus on the cardiac surgeon to call vascular. Say this is the case I think we want to do together. So it doesn't always happen yet.
And I think, too, one of the biggest learning points as we continue to do them has been room setup, how to get all the text in there, how to get perfusion in there, and then some of the details about what goes where and timing-wise with the stent and circ arrest and IVUS. And so I think just in the past 5 cases that I've done with you guys, I think we've really advanced and continued to improve. And I think the one we did who had symptoms for 12 hours and a lactate of 14 before we started, he's alive. We're
Right.
doing very well.
We've had excellent success. I think at least every patient I know of that we've been involved in has had a good outcome. Again, there's no long-term data for this, but it's based on a theory which seems pretty reasonable, and it's working well, and it's going very quickly. The ones that we've done together, the endovascular stent graft deployment, which occurs antegrade under circulatory arrest, has been very, very quick and hasn't added a substantial time or risk, I don't think.
Right, and you know, we can deploy this device while you guys are rearming the patient. So you know, we don't have to take any of your. We know the hypothermic circ arrest time is crucial. You want to minimize that, so we can deploy that right away, and that's the message we're trying to convert. And these are patients that only 5 years ago would have died. They wouldn't even see the next day. This was it. And now they're walking out of the hospital. So it's a great thing, and we hope to continue doing it.
Before everybody leaves, or before the next question, I just wanted to let you know that both Dr. Titus and Dr. Manunga are PIs on some 2 enrolling studies that we have at the foundation, and that will be at the beginning of the presentations. If you go back to the PDF once we get it posted on the MHIF website, as well as there's a book, I believe it's being distributed this week into the workrooms. Are there any other questions? Thank you very much.